We're going to move on now to discussing care from behind a computer screen. COVID-19 has created a situation where many people were afraid to come to healthcare facilities because that, of course, is where patients potentially with COVID were concentrated. And at the same time, of course, healthcare workers needed to be protected from potentially infected patients as well. So for the next 30 minutes, we're going to discuss how we set up a telemedicine program and conduct care from behind a computer screen, along with the limitations that come with that. We're going to hear from Patrice Callagy. She's the Executive Director for Emergency Services here at Stanford. We'll also hear from Christopher Sharp. He's a physician and the Chief Medical Information Officer at Stanford Healthcare, as well as being a clinical professor of medicine at the Stanford School of Medicine. And finally, Dr. Mickey Halberthal. He is the Assistant Professor at the Technion Medical Faculty and Director and General and Chief Executive Officer, Chairman of the Teaching Center for Trauma Systems, Emergency and MCS at the Rambam Healthcare Campus. Patrice, why don't we start with you?
Okay, good morning and good evening. And let me share my screen here. Okay, so Stanford ED COVID surge began when Silicon Valley, which Stanford Hospital resides within, made international headlines as the epicenter for the United States in COVID spread. Now, a shout out to our Santa Clara County Public Health Department and Dr. Sarah Cody, who is one of our 5 local counties who actually took the drastic steps to be the first in the country to implement shelter in place to decrease that spread. But in the meantime, we were in flu season, and every patient with influenza-like illness who would normally stay home with their sore throats or runny nose went to the emergency department because of the fear of COVID. Additionally, we were seeing patients who were told they were exposed to positive COVID patients or family members or coworkers, so they were coming in. And additionally, as our occupational health was preparing for this surge and expanding, they sent our own employees to the emergency department. So overnight, we were seeing an additional 100 to 150 patients who were patients under investigation for COVID. And we needed to isolate these patients to keep them at social distancing. And we also were burning through a great deal of PPE. And although we never ran out of PPE, we were asked to conserve as much as possible. So our ED leadership group was already meeting twice a day. That consisted of physicians, OEM, and nurses to develop workflows in participation of surge. However, our first 2 workflows did not work as we were already in winter still, and it wasn't conducive to have patients outside in tents. So we decided to implement something we had only simulated in 2009, and that was for a potential surge of flu patients through a garage system. Now, it's important to recognize that Rambam has the gold standard in alternate care hospitals within a garage, but this was a much simpler operation. And so overnight, we actually implemented a garage, and it took a village of all our departments within the hospital to implement this. We did not have Wi-Fi in the garage. It had to be implemented. We didn't have electricity. We needed to use a generator. We needed permission from a fire marshal, from the State Department to run an alternative care department. And we needed our computers so our IT folks could work so we can actually document it in our EMR and have a consistent record of these patients being seen through the system. We wanted to make it as lean as possible. So we would have a screener see every patient. We would register the patient. The RN assessment and testing would occur, the MD visit and discharge. We wanted it as quick and safe as possible as a pit stop during a car race, although our parking folks made sure cars were not racing through our garage system. A key component of this was our RN screener, who would see every patient, whether they were driving up or whether they were actually walking up. That nurse would create a secure text messaging system through our phone software of the staff in the garage, the MD who was located remotely within a console room in the emergency department, registration, which was also remotely within the emergency department, and the screener. If the patient, based on questions, was stable enough for the garage, they would take a picture of the patient's ID and attach a phone number, say if they were walking or if they were driving, and some fast texters could even put what type of car the patient was coming through. These patients were registered remotely, saving any exposure to our registration staff and decreasing PPE. And you can see from the slide that we have our walk-ins and our cars right here. And then they were directed with signage to the garage care system. For the walk-ins, we used our decon area so that patients, and we had dividers and 6 feet distancing so that they were secure where they were. Now, the RN in the garage would do a full triage. They would also do vital signs. And initially, the first week, about 7% of the patients had to be sent back to the emergency department and deemed inappropriate for this garage system. But after that first week, as the screener became more proficient, they went down to much less than 1%. The nurse would do the triage and place it in our electronic medical record. Per protocols, they would do a swab, a flu swab, and a COVID swab. And if they deemed the patient needed a strep screen, they would also do that per protocol. They would document a dot phrase that said the patient gave permission for a telemedicine visit, and they would notify the physician through the EMR that the patient was ready to be seen and which telemedicine card to actually use to see the patient. Now, the physician would call in, this card would automatically answer, and they would confirm what the nurse had written, speak to the patient, determine if there was any other conditions. Sometimes there were, such as croup or mild asthma, and we would give additional discharge instructions. Now, we did use paper discharge instructions, even though I'm highly against paper just for efficiency. And those paper discharge instructions included how to sign up for My Health, where the test results would appear. Initially, it took up to 2 days. We are now down to 4 to 4.5 hours for our PCR test. And the patient would then leave the garage system. You can see that initially the patients were seen within the ED or outside the ED. We did trial the tents. They really didn't work with the weather. And then we became extremely efficient through the garage system. We had the garage system open for a short period of time, then started managing the patients in front of the ED. We later opened the garage system again. However, due to smoke, we brought our staff back in. It was open air and the smoke was too much for the staff. And just as note, patients going through this system actually had very high satisfaction scores. And of all the patients seen, none of them returned for worsening symptoms or a revisit within 7 days of being seen within the garage system. This is just an algorithm of how we determined who would be seen internally and externally. Now, at the same time, I was challenging our IT department to come up with a video self-answering system within the main ED in our private rooms, and they came through. Within a week, they had procured 100 different iPads and scans, and the system they used through Zoom was self-answering. So after the initial visits through a doctor or nurse in full PPE, we could talk to the patient, answer call bells, have the interpreter, social workers speak with the patient through these iPads. The patients appreciated because they were seeing staff without full PPE on. And you can see it was a very clear video. And even for resuscitation patients, our ICU teams or consult teams would be outside the room viewing the iPad and providing instructions. Pharmacy was outside the room and could hear what medications needed to be drawn up. So it was extremely efficient and limited the number of exposure and drastically decreased the use of PPE. Again, just a picture of how clear the provider could see the patient in the room. Because this technology was brought out overnight, we laminated some QR codes, and a 1-minute video demonstrated how to actually use the system. And it was highly used in the first few months of COVID. This is just the stand that we eventually purchased to secure the iPad so that our patients didn't seem to borrow the iPads off of the rooms. And I will turn it over to our next speaker.
So once again, hi to everyone. when we have the pandemic, and especially now that we are using our underground facility that has huge capabilities, I talked about it yesterday. You can see the daily census of Rambam from the beginning in March, and you can see basically the three waves. And unfortunately, as I was saying yesterday, this is from the end of last week, and we can see that we already unfortunately see that we are gathering more patients because of the rate of infection in Israel. This is again one of our dashboards that shows us the amount of patients that we have and the amount of staff that we have in isolation because we needed all those equipment and all the software in order to run logistically and being extremely efficient with the human resources. All the log booking with our emergency software that does all the preparedness for any emergency. And this time the emergency was COVID. We used it, and between the different headquarters, all the data and the information was transferred, and we can see also the amount of critical elements like ventilators, beds, and the rest that was monitored all the time. One of the exciting things that we had throughout the event is the effect of all kind of the industries and the academy around Rambam that came to help us with all kind of unmet needs. And this is, for instance, the pooling system that we started and we published it initially, and we are now using it in order to identify patients. We're also running now the labs for COVID in the Israel Tel Aviv airport. All kinds of modes of trying to identify patients early using verbal speech in the telephones, and also using all kinds of respiratory failure measure lung fluids. All the protection gears. This is again with the Technion. All of us that use PPEs, and we know how hot is it inside, and using some kind of ventilation inside in order to be able to work with the PPEs for longer period of times. And because all the PPEs were extremely cumbersome, this is another solution that we use as a part of the overall protection as a hijab. And we had all kinds of tests to see the effect of the different component of the PPE, having a patient basically with this dummy and ventilated, and we could see with the ultraviolet light and see what was the spread of the, and I think Itai is going to speak about it in a few minutes. One of the major things is when we started to deal with the pandemic, and it was discussed with our colleagues here at Stanford, is that we needed to do medical care from far using all kinds of modes. We use BioBeat. They have a model that put on the chest of the patient, and that produces 16 different cardiac output parameters, ECG, and also temperature and the rest. And by that, the patient could be mobile and walk around and will be still monitoring it. And use all kinds of CTVs and all kinds of communication systems in order to be able to track patients and have a direct contact with the patients. Another issue that we had is that we had lacking of equipment, and the government was trying to get whatever they could. And obviously they bought stuff that we are not familiar with, computer systems, monitoring system, ventilators, syringe pumps. And one of the things is, how do we get all the data from this? Because we had no connection with our system. And this is one of the companies, Rafael, that basically captured the screen of the monitoring and took out all the data from the most different monitoring and put it on a screen, and we even be able to take alarms and all kind of things, and basically putting into the patient EMR, and or getting all the information, because again, one of the major thing is how to run the system and get lots of information very efficiently. One thing that Oren mentioned yesterday is, again, part of the command and control system. How do we control the patient surrounding and see who is around? We know that all the stuff is covered, and in the underground hospital, the acoustic is extremely bad. So how do they communicate between each other? And we used a specific system of communication with that had the headquarters. Everybody was on the communication, every ward by itself, having these phones that gave us the capabilities of getting different channels of communication. Each and every staff of the hospital that went down into the underground hospital has to carry one, and by that be able to communicate with his own staff. But this is only part of the thing, because the other thing that you get a location, and this is the Google map of Haifa and the area of the hospital. And once you go in, you can see the structure, the layout of the structure of the underground hospital, and you can see the different staff people that are around. And even if there is any kind of an emergency, you can, and that, you know, for instance, a CPR, and you get staff coming from all different areas on the wards, you can make them one channel that will be able to speak to each other. And you can see each bed, who is the patient, if it's monitored or not. And the near future comes that when a physician will be standing next to a bed, he will be able to talk speech to text immediately to the patient's file that in the EMR. And we can talk to them also. I will conclude my talk and show you a short clip that shows the underground hospital. We are coming down, as I said, the underground hospital is 5 acres, 60 feet below level and 27 feet between sea level. And you can see and appreciate the size of the place and the amount of people that you can see using it all over, and the ability to have a capacity of 770 patients inside. You can see the amount of workload that we had. All the equipment that's spread around, the ventilation, and it's really is a full hospital, not a parking lot that acts as a hospital, but a full state-of-the-art hospital with all the equipment. You can see the panels that supply oxygen, lots of workers that do, the orderlies that did everything. And it's funny to see us totally protected and the patients going around us without any protection. It's really weird in a way. And obviously, putting the protecting gear and taking them off, all those were major issues. As we are short with time, I will stop over here. Thank you.
Thank you so much, Mickey. And finally, let's hear from Dr. Christopher Sharp, Topher Sharp, who will speak about the telemedicine program here at Stanford.
Thanks so much. My name is Christopher Sharp. I'm the Chief Medical Information Officer here at Stanford Healthcare, and I'm also a member of our faculty. And I'd love to just, I'm not going to use any slides, but I'm going to just tell you a couple of brief stories here about our experience and share those with you this morning. So thanks for the opportunity. I think that I start by thinking about three big areas for us when I think about this idea of care from behind the computer screen. The first was our transformation. The second would be stabilization. And the third is getting into this overused term of a new normal. So I just want to talk briefly about the transformation that occurred for us early in the calendar year 2020. Was dramatic, of course, in the setting of the need for an immediate response around safety and around access for our patients, we immediately had phone calls coming in with many questions because there was so much unknown at that time, which meant that literally our call line went more than 100% over prior calls coming in. And so we needed to make sure that we had appropriate intake around that. We also found that because individuals were sheltering in place, they were looking out for other ways to connect with us. So the number of email messages from our existing patients went up in many cases 30 or 40% above their normal, as individuals were unable to leave their homes or afraid to leave their homes. And we saw dramatic volume shifts. Our ambulatory care went from about 80,000 visits per week to 15,000 per week, 15,000 per week overnight. But what also happened during that time, of course, was that we dramatically changed the way in which we interacted. And that meant, for instance, that we shifted, within 3 weeks' time, we shifted to video as our primary interaction method in our ambulatory center, with 70 up to 80% of all ambulatory visits happening by way of a virtual contact point, literally within 2 weeks' time. We were up and running at that rate. And that helped us to stabilize our access so that patients were still able to see us. But it was a dramatic transformation. It meant for us that over the course of that pandemic time until about September, 182,000 patients had their first video visit with Stanford. So there was a lot of mutual learning that had to happen very, very fast, because we also had 86% of all of our providers providing a virtual visit or a video visit during the course of that time. A pretty remarkable and dramatic change for us that had to happen very rapidly. In addition to this, we needed to open up our clinics in order to provide access again for those who either were clinically not appropriate for a video visit or who were, because of other reasons, needing to have a video visit. And so we needed to reopen that volume. One of the key things we did around that was to create a contactless experience for those patients who needed to see us. So what that meant was that patients could go online, they could select their visit, they could go ahead and do some of those preparatory steps for when they came into that visit, meaning that they would be able to go in and confirm the reason that they were coming, do their consent if they needed to for their care, answer key questions about their visit and their needs, update their insurance, those types of issues, and then use that same system to navigate to the clinic, and then to use that same system to note their arrival. So literally, the phone in their pocket hits a beacon in the waiting room and automatically checks them in and says, "You're here, have a seat." No need to even approach the desk to check in because you're already checked in electronically, minimizing the contact experience and maximizing that opportunity to reduce the infection spread. And that even happens at the level of when the patient leaves the clinic, because we don't even need to hand them papers when they leave the clinic. All the instructions and all their next steps are offered to them electronically. And we've managed that because we have about 85% of all patients on our online portal with us when they come in to have their visits with us. So what this really showed was that we leveraged the opportunity that we had to engage with patients electronically, and that then patients could make the very most value out of that. I'd also like to spend a moment talking about our hospital experience. As was shown by Patrice, room-to-room telehealth was extremely important to reduce the amount of physical touches. That was really important both for those patients who were hospitalized with COVID, but also very important for those patients hospitalized with significant illness for whom reducing contact was an imperative. So we have many patients who are immunocompromised, on chemotherapy, have a bone marrow transplant. So we instituted more than 200 rooms in our hospital, literally within those first couple of weeks, to have room-to-room telehealth available. That was used by our clinical staff in order to engage with patients in a contactless method, but also, as it turns out, very important for visitors. We had to dramatically restrict our visitation policies so that patients now, in the midst of what were very significant crises, were unable to have their loved ones by their sides in the way that they normally would. And consequently, it made a very big difference that we could not only open up video chat for health providers, but we could also open up video chat for family members. There's a fantastic story of a patient who is an older patient with dementia, had a lot of difficulty orienting and understanding what was happening around her. Every day, her daughter would call in by way of a video chat and spend about 2 hours online with her, talking with her, telling her stories, helping her understand what was happening in the hospital. And her nurses and others came to understand that this was one of the most important parts of her day and one of the most important parts of her care. So a very important aspect that we really needed to open up and make available. I want to just briefly address stabilization, because as the months progressed, it became more and more important that reopening and retaining these benefits and capabilities became really critical. That involved a couple of elements. First of all, it meant that we needed to look at the quality, the safety, and the equity of how we were using these technologies and these capabilities. From a quality standpoint, we needed to assure that we were providing patients the right care. So that meant and involved checking for the types of care that was rendered, using standard quality evaluation methods to assure that we were providing the right levels of care and that the right outcomes were attained. As an example of that would be assuring that those patients who were seen on a virtual visit did not require ED visits or in-person visits that were unexpected in the days to follow. Social equity was also very important, and that involves things like non-English speaking members of our patient panel, or those who might be in zip codes where they had decreased access to online services and capabilities. So we've looked at that from an analytics standpoint, and we've initiated a number of interactions in order to make that possible, including using phone only where it's required. But fortunately, and perhaps it's a phenomenon of Silicon Valley, we've been very overall able to maintain the same types of interactions at the same percentages across those different social groups. We've also been engaged in community needs, and this involves extending out services into areas like schools or those other first responders, where we've invoked apps that help them in order to engage, achieve, and get testing when they need it, and then escalate all the way to care when they need that. And last, I'd like to close thinking about the new normal. The new normal for us involves a number of important challenges. One of them is that in our community, a number of primary care and specialty care providers are no longer providing the same level of services. The pandemic has not only caused health effects, but it's caused financial effects out into the community. And so many of those providers, where they might refer to Stanford or they might lean on Stanford's care, now are not out there in the providing community in the same way that they were. So part of what we're looking at now is extending services out into that community in ways that are impactful and supportive to the care community. The second is, of course, there are a lot of new market entrants, things like a teledoc or online services, many new apps. That means that we also have to think about how we work with those within our ecosystem. And the last is that I think as we approach the winter months, it's been described that there will be a lot of components that may escalate here in terms of COVID itself, influenza, or other changes that happen during winter months. And we need to make sure that we're planning for those completely and fully, including leveraging our digital assets. With that, I'll close and say thank you very much for the opportunity to address you.